Hyponatremia, a condition characterized by low sodium levels, is a frequent challenge in emergency medicine. Defined as a serum sodium concentration below 135 NaCl, it is one of the most prevalent electrolyte imbalances. Understanding hyponatremia is crucial for healthcare professionals in emergency medicine. It can lead to severe neurological consequences demanding our attention. This guide aims to equip providers with the knowledge to diagnose, treat, and prevent complications. Let us demystify hyponatremia and deliver the highest standard of care. Hyponatremia poses a significant threat to hospitalized patients. It affects up to 30% of this population. This imbalance can lead to severe neurological symptoms. Early recognition and intervention are crucial. Hyponatremia, a common electrolyte disorder characterized by low sodium levels in the blood, poses a significant health burden, particularly among hospitalized patients. Studies indicate that hyponatremia affects a staggering 15 to 30% of hospitalized individuals, highlighting its prevalence as a silent epidemic within healthcare settings. This high incidence underscores the critical need for heightened awareness and proactive management strategies to address this often overlooked electrolyte imbalance. Several factors contribute to the increased susceptibility of hospitalized patients to hyponatremia. Underlying medical conditions such as heart failure, cirrhosis, and kidney disease can disrupt the intricate mechanisms that regulate sodium and water balance in the body. These conditions often lead to fluid overload or impair the kidney's ability to excrete excess water, ultimately diluting the sodium concentration in the bloodstream. Medications commonly prescribed in hospitals, including diuretics, antidepressants, and certain antibiotics, can further exacerbate the risk of hyponatremia. Diuretics, while essential for managing fluid overload, can inadvertently lead to excessive sodium loss through urine. Antidepressants and some antibiotics can disrupt the hormonal control of water balance, leading to increased water retention and subsequent hyponatremia. The aging process itself contributes to an increased vulnerability to hyponatremia. As we age, our kidneys become less efficient at regulating fluid and electrolyte balance, making older adults more susceptible to developing hyponatremia, particularly in the setting of acute illness or hospitalization. Recognizing the high prevalence of hyponatremia and its multifactorial etiology is paramount for healthcare providers to implement effective preventive measures and ensure timely diagnosis and management. Sodium, a crucial electrolyte, maintains fluid balance and ensures proper nervous system function. It regulates water movement across cell membranes through osmosis. Low sodium levels cause water to enter brain cells, leading to swelling and cerebral edema. This increases intracranial pressure, disrupting brain function and causing AMS. Prompt treatment is essential to prevent irreversible brain damage. The brain's response to sodium imbalance. Altered mental status is a hallmark of significant hyponatremia. It ranges from mild cognitive impairment to life-threatening coma. This arises from the brain's response to osmotic stress. The brain initially transports electrolytes out of its cells. If sodium levels continue to fall, cerebral edema occurs. Clinical presentation varies with severity and acuity. Mild hyponatremia may manifest as subtle cognitive changes. These symptoms often go unnoticed, delaying diagnosis. Moderate hyponatremia shows more pronounced symptoms. Patients may experience confusion, disorientation, and gait disturbances. Severe hyponatremia can lead to seizures. Profound hyponatremia is a medical emergency. Immediate intervention is required to prevent brain damage. Table of Contents, Part 3. Classification of hyponatremia. 1. Classifying hyponatremia, a roadmap to effective management. 2. Time is brain acute versus chronic hyponatremia. 3. Decoding volume status, hypovolemic, euvolemic, and hypervolemic hyponatremia. Section 1. Classifying hyponatremia, a roadmap to effective management. Hyponatremia, a common electrolyte disorder, presents a multifaceted challenge in clinical practice. Effective management requires a systematic approach to classification. Classifying hyponatremia involves considering factors like time course, symptom severity, and volume status. These parameters guide the safest and most effective treatment plan. Section 2. Time is brain acute versus chronic hyponatremia. Time is brain in hyponatremia. Acute hyponatremia, a drop in sodium within 48 hours, is a medical emergency. Chronic hyponatremia develops over days to weeks, allowing brain adaptation. Treatment differs. Acute needs rapid correction with hypertonic saline. Chronic requires cautious management to avoid complications. Section 3. Decoding volume status, hypovolemic, euvolemic, and hypervolemic hyponatremia. Volume status is crucial in classifying hyponatremia. Assessing fluid status as hypovolemic, euvolemic, or hypervolemic helps tailor treatment strategies. Hypovolemic hyponatremia results from fluid loss. Euvolemic hyponatremia often stems from SIAD. Hypervolemic hyponatremia accompanies fluid overload conditions. Treatment varies: fluid resuscitation for hypovolemic, fluid restriction for euvolemic, and diuretics for hypervolemic. Table of contents, Part 4 clinical presentation about 3 sections. 1. The subtle whisper of mild hyponatremia. 2. The urgent call of moderate hyponatremia. 3. The dire warning of severe hyponatremia. Section 1. The subtle whisper of mild hyponatremia. Hyponatremia, a chameleon in electrolyte disturbances, can manifest with a broad spectrum of clinical presentations. In its mild form, it whispers its presence with subtle neurological symptoms. Patients may exhibit nonspecific complaints like fatigue and cognitive impairment. These symptoms can significantly impact daily functioning and quality of life. Headache and gastrointestinal disturbances may also signal mild hyponatremia. Early recognition is crucial for effective management. Section 2. The urgent call of moderate hyponatremia. As hyponatremia advances from its subtle beginnings to the realm of moderate severity, with serum sodium levels dipping between 120 and 129 NaCl, the clinical presentation takes on a more urgent and alarming tone. The brain, now facing a more significant osmotic challenge, begins to exhibit more pronounced neurological dysfunction, demanding our immediate attention. Confusion, a hallmark of moderate hyponatremia, disrupts the clarity of thought and perception. Patients may appear disoriented to time, place, and person, struggling to answer simple questions or follow basic commands. This confusion can fluctuate in intensity, waxing and waning throughout the day, further complicating the clinical picture. Lethargy, a state of profound tiredness and apathy, further underscores the neurological impact of moderate hyponatremia. Patients may exhibit a lack of motivation and interest in their surroundings, preferring to sleep for extended periods. This lethargy can progress to stupor, a state of reduced responsiveness, where patients require vigorous stimulation to elicit a response. Gait instability emerges as the electrolyte imbalance disrupts the intricate pathways responsible for balance and coordination. Patients may develop an unsteady gait, characterized by a wide stance and a tendency to sway or stumble. This gait disturbance, often mistaken for intoxication or cerebellar dysfunction, increases the risk of falls and subsequent injuries. Muscle cramps and weakness, often overlooked in the setting of neurological dysfunction, can provide valuable clues to the diagnosis of moderate hyponatremia. These muscle symptoms arise from the electrolyte imbalance disrupting the normal excitability of muscle fibers, leading to involuntary contractions and reduced muscle strength. Section 3. The dire warning of severe hyponatremia. Severe hyponatremia, a life-threatening condition, demands immediate intervention to avert catastrophic neurological consequences. The brain faces an overwhelming osmotic burden, teetering on the brink of irreversible damage. Seizures reflect the brain's desperate attempt to cope with the profound electrolyte imbalance. These seizures can manifest as generalized tonic-clonic convulsions, or as more subtle focal seizures. Coma represents the most ominous sign of severe hyponatremia. Patients in a coma exhibit no signs of awareness or purposeful movement. This loss of consciousness stems from overwhelming cerebral edema. Respiratory depression arises as the electrolyte imbalance disrupts brainstem centers. Slow and shallow breathing patterns can lead to respiratory acidosis and arrest. Brainstem herniation occurs when the brain herniates through the skull's base. This compresses vital brainstem structures, leading to rapid neurological deterioration and death. Table of contents, Part 5, Diagnostic Approach. 1. The art of clinical suspicion. 2. Laboratory investigations. 3. Imaging modalities. Section 1. The art of clinical suspicion, recognizing the clues. Diagnosing hyponatremia in the emergency department starts with clinical suspicion. A thorough history and physical examination provide invaluable clues. The patient's narrative holds vital information about hyponatremia's potential causes. Inquire about symptoms, fluid intake, dietary habits, and medication use. Underlying conditions like heart failure or kidney disease increase hyponatremia risk. Medications, especially diuretics and SSRIs, can lead to hyponatremia. Diuretics cause sodium loss, SSRIs disrupt water balance. Physical examination reveals volume status, crucial for classifying hyponatremia. Assess skin turgor, mucous membranes, and edema. Hypotension and tachycardia suggest hypovolemia. Neurological examination gauges electrolyte imbalance severity. Assess mental status, cranial nerves, motor strength, and reflexes. Subtle cognitive deficits may indicate early hyponatremia. Severe impairments signal emergencies. Section 2. Laboratory investigations unmasking the electrolyte imbalance. Laboratory investigations confirm or refute clinical suspicions. For hyponatremia, serum sodium below 135 NaCl confirms diagnosis. Serum osmolality distinguishes true hyponatremia from pseudohyponatremia. Urine osmolality and sodium concentration provide insights into water retention or loss. Section 3. Imaging modalities, peering into the brain. Imaging modalities provide a window into the brain, assessing cerebral edema and ruling out other pathologies. MRI, the gold standard, reveals brain structure changes and cerebral edema. CT scans, though less sensitive, are useful in emergencies for rapid evaluation. EEG records brain activity, crucial for evaluating seizures in severe hyponatremia. Imaging is essential for severe neurological symptoms to assess cerebral edema and other conditions. Navigating the treatment landscape, a delicate balancing act. Treating hyponatremia is like a tightrope walk, balancing correction and avoiding neurological complications. Rapid correction can lead to osmotic demyelination syndrome, causing severe neurological deficits. We must approach treatment with caution, ensuring a safe return to electrolyte balance. Section 2. Correcting hyponatremia, a gradual ascent to equilibrium. Correcting hyponatremia requires a gradual and controlled approach, addressing the underlying cause and tailoring treatment to the patient's needs. For mild cases, fluid restriction or medication adjustment may suffice. Severe cases need careful IV fluid administration and monitoring. Hypertonic saline is used cautiously to avoid complications, ensuring a safe ascent to electrolyte equilibrium. Close monitoring of serum sodium levels and patient status is essential throughout the treatment journey. Managing acute symptomatic hyponatremia, a race against time. Acute symptomatic hyponatremia demands swift action to prevent devastating neurological consequences. Imagine a firefighter rushing into a burning building. Every second counts. Similarly, in managing acute symptomatic hyponatremia, urgency and precision are crucial. Our primary weapon is hypertonic saline, a concentrated salt solution. Administered intravenously, it rapidly raises serum sodium levels. However, it must be used cautiously to avoid osmotic demyelination syndrome. Our goal is to alleviate acute neurological symptoms and prevent further deterioration. Seizures, a common manifestation, require prompt treatment with anticonvulsant medications. In this high-stakes scenario, time is of the essence. Navigating chronic hyponatremia, a steady hand and a watchful eye. Chronic hyponatremia requires a measured approach, as it develops gradually. Imagine a gardener tending to a delicate orchid, making gradual adjustments. Similarly, managing chronic hyponatremia involves fluid restriction and careful monitoring. Fluid restriction aims to reduce the body's water content, allowing sodium levels to rise. In some cases, salt supplementation may be necessary. Medications can both cause and treat chronic hyponatremia. Diuretics, essential for managing fluid overload, can worsen hyponatremia. Adjusting diuretic dosages or switching classes may be necessary. A patient and observant approach is key. Tailoring treatment to volume status, a personalized approach. Volume status guides our treatment decisions for hyponatremia. Hypovolemic hyponatremia responds well to isotonic saline. Euvolemic hyponatremia often stems from SIAD and requires fluid restriction. Hypervolemic hyponatremia accompanies conditions like heart failure. Managing it involves fluid and sodium restriction. Diuretics help eliminate excess fluid but must be carefully individualized. In resistant cases, advanced therapies like VAP-TANs may be considered. Tailoring our approach ensures effective management. Each patient's volume status is crucial. The importance of vigilance. Monitoring for fluctuations and complications. Treating hyponatremia demands constant vigilance. Imagine a captain charting a course relying on navigational tools. Similarly, we rely on clinical judgment and laboratory monitoring. Serum sodium levels require frequent monitoring. For severe hyponatremia, hourly monitoring may be warranted. We must remain attuned to subtle shifts in the patient's condition. Worsening mental status demands immediate attention. Fluid balance requires close monitoring, especially with intravenous fluids. Vigilance ensures safe navigation through hyponatremia. Preventing osmotic demyelination syndrome, a triumph of gradualism. Osmotic demyelination syndrome arises from overly rapid correction of hyponatremia. Imagine a deep-sea diver ascending too quickly, risking decompression sickness. Similarly, rapid correction disrupts the osmotic balance within brain cells. Preventing this syndrome hinges on recognizing chronic hyponatremia. The rate of sodium correction should not exceed 8 to 10 milliequivalents per liter per 24 hours. Close monitoring of serum sodium levels is paramount. Frequent assessments allow us to detect sudden rises in sodium levels. Our goal is a slow and steady correction. Gradualism ensures safe passage through hyponatremia. Special considerations in hyponatremia management. Each patient presents a unique physiological puzzle. Elderly patients require a cautious approach due to age-related changes. Slower rates of sodium correction and frequent monitoring are essential. Patients with adrenal insufficiency pose a unique challenge. Intravenous hydrocortisone may be necessary to restore hormonal balance. Medications deserve special scrutiny in hyponatremia management. Reviewing the patient's medication list and adjusting dosages is crucial. Pregnancy adds complexity to hyponatremia management. Treatment decisions must weigh risks and benefits to both mother and fetus. Mastering hyponatremia, a call to action for patient safety. Hyponatremia has the potential to unleash neurological consequences if left unchecked. Mastery in medicine represents a lifelong journey of learning. Hyponatremia management demands our unwavering commitment. Early recognition allows for timely intervention. When faced with moderate to severe hyponatremia, we must act swiftly. We must avoid the treacherous allure of overcorrection. Embrace a culture of vigilance, monitoring beyond laboratory reports. Vigilance ensures safe passage through hyponatremia. Let us rise to this challenge, armed with knowledge and compassion.